Hey everyone, I'm John Lynn, the founder and chief editor of Healthcare IT Today, and we're excited to bring you this great interview with Tom Leary. He's VP of Government Relations at HIMSS. Hey, welcome, Tom.
Hey, thanks, John. Thanks for having me.
Yeah, so I'm excited to talk with you. We were supposed to do this at HIMSS in Orlando. Unfortunately, we have to turn it all virtual, but at least hopefully we can push some of the learning out. And I guess I'd be remiss if we didn't start off with some sort of coronavirus COVID-19 question. So as VP of Government Relations at HIMSS, you work in DC and all the legislation that's happening around health IT. What's been the impact of coronavirus on health IT legislation and also regulation, which I think is another part of your job?
So, great question, because there has been a good amount of activity just in the last 10 days, and I want to first send a hello out to everyone, and I hope they're staying safe and following the instructions of their local community. What we're seeing at the congressional and then the federal agency perspective is first Congress has stepped up and given some additional waivers for the Secretary of Health and Human Services to be able to figure out how to leverage telehealth on in more ways, specifically for healthcare organizations and providers to be able to leverage telehealth resources for patients. And the initial agreement was in the supplemental that was passed just a few days ago, and then signed by the president, gives the secretary the approval or the opportunity to waive certain requirements if an individual has seen a physician within the last 3 years. What that didn't do was take into account that hey, you might be creating a situation where just by leveraging telehealth, there might be an opportunity to keep patients who might be sick away from the doctor's office. So the requirement of must have been seen face to face in the last 3 years was a bit of a hurdle. So what Congress came back around with just in the last few days is addressing that by adjusting it so that providers have a little bit more of a leeway. The secretary has more of a leeway to be able to keep patients who might be sick, truly use the technology in a way that allows the patients to stay at home, engage with the provider. There might be an opportunity in the near future to be able to also address some of the remote patient monitoring, so that you don't have to come into the office. You can truly leverage the telehealth technology, the connected health technology. And at the same time, the secretary and administrators of Burma and the CMS folks have started to figure out different regulatory responses to make it easier on Medicare providers to seek reimbursement, but also to be able to, they just put out, just literally moments before we started our conversation, they just sent out a new update as to what they're allowing to be covered for telehealth. So it's really Congress and the agencies and the administration are working very closely together on current opportunities to address the COVID-19. And then we understand that they're also working on additional supplementals to be able to tweak around the edges.
Yeah, it definitely seems like COVID-19 is going to push forward telemedicine and telemedicine reimbursement. I also heard the president say that there were going to be some waivers for HIPAA compliance as well. So it'll be interesting that I've heard some people say that maybe those were not as expansive as they should be, that they're pretty narrow, but I imagine that will continue to evolve as they do it. And I think that would be a good help to many organizations. He even talked about is FaceTime HIPAA compliant and waiving that regulation to be able to create those type of communication opportunities. I think there's an interesting balance we're in as far as protecting the privacy, but also enabling patients and providers to do what they need to do.
Exactly. And what I've seen over the last several days, just since Friday, is even with the declaration of the national emergency, the president and the administration have been listening. We've had some email exchanges with both the HHS front office and CMS around, hey, this has been the initial experience, and this, for example, there's some state laws that preclude state-run hospitals. So, and you think of any of the healthcare organizations that are, connected with University of, fill in the blank, Texas or Kentucky, et cetera. There are certain state laws that preclude the donation of state resources to non-state entities. So some of the state hospitals that are associated with, University of Texas in this case, could not, they had testing kits, but they couldn't donate across the street to a nonprofit or a for-profit hospital because there are state regulations. So HHS has taken that into account and figured out how to potentially weave that into their the response to the national emergency. Also working with state governments to see if there's anything governors need to any action they need to take. So they're very much interested in learning, making adjustments, and then learning from the adjustments.
That's great. So let's shift gears a little. I think it was interesting. We originally were planning to talk about 21st Century Act, but obviously we need to talk about some of the COVID implications. But it was interesting when the 21st Century Act was announced. I was on a call with Seema Verma and a number of other people, and the press were really kind of hammering her, saying, "Why are you talking about this when coronavirus is so important and two of you are on the task force?" And she interestingly said, well, we're not going to stop the operations of HHS, and while we're dealing with it, we need to be able to do multiple things. So I thought it was an interesting insight. I wonder if her tune's changed a little as things have continued to evolve. But that said, I think that is their goal, is, hey, let's proceed forward. So I guess in this interview we'll do somewhat the same and proceed, and let's talk a little bit about the 21st Century Cures Act legislation. What are your initial thoughts on it, and what are you seeing and hearing?
So we're very excited to finally have final regulations to be able to engage with our members and the healthcare community on. If you recall, this was a process that began really in 2014, 2015 with the initial legislative discussion around 21st Century Cures. And when the legislation was finally signed by President Obama just before he left office, the anticipation of a interoperability and information blocking rule, as well as now the CMS interoperability rule, and provider burden and patient engagement components of their regulations, have really been much anticipation that they would come out. I would say that the timing of getting it out there so that folks can start to adjust, and the reminder by both ONC and CMS that the start dates are really contingent upon when the Federal Register notice gets officially published. All of those little nuances are causing some confusion, but overall it's great and of great importance. We were even talking earlier today that this is the biggest piece of regulatory activity really since meaningful use it's having will have as much of an impact. So where we're really focusing our energy on educating the members while they're responding to COVID-19, as well as getting to understand what's in the regulations. Several key areas. First of all, the information blocking is absolutely up front and center for the members and for the healthcare community. What does it mean to actually information share? What does it mean about if you're information blocking? I think the addition of by ONC of the additional exemption that was put into the final rule as a result of community feedback is a real positive that ONC was listening to the community. And I get the other areas that we're focusing on, of course, the standardization of FHIR version 4, so that apps in the app, the API environment needs to be able to build against Fire version 4. Really creates that level, that baseline that a lot of folks are looking for. It's going to cause some organizations that were building apps or building use cases against earlier versions of Fire to have to up their game to speed up their processes to make sure that that they build towards the newest version of Fire. But it will also, by putting that into regulation, it creates that baseline that then anyone can, that has concerns, hospitals and healthcare systems in particular, who have concerns about who they need to share with, and will the either sharing, the other party or the app that the patient is bringing in, will they meet the standards that the hospital or the healthcare system puts on, for security and for privacy. That really helps with baselining. I'd say the third piece that we're absolutely paying close attention to is the 2015, the updates to the 2015 certification, what that means for the community, and how they're dovetailing that information with the US CDI, the graduation to the US CDI. Pausing there, it's the other piece that we're hearing from our members that I think is real important for us to talk about is the timeline. That have we created a too long or long enough or not long enough runway for healthcare community to be able to be ready for and compliant with this new final rule. Patient advocates have been out front saying 24 months from the decision to from the posting in the Federal Register seems a little bit long to be able to then truly get that information in patients' hands. On the flip side, others in the community are saying that 24 months is not long enough. So, in my mind, if nobody's perfectly happy, then you've probably nailed it. That's about the right amount of time. Historically, HIMSS as an organization has said 12 to 18 months between posting in the final rule to actually requiring in a regulation. So having that true 2-year runway is probably going to prove to be very important, so that we don't have to provide extensions later in the process. From the CMS perspective, I think the most important portion of the rules that we're hearing from members are twofold. The impact on who has to participate. What is the impact on the payer community when they're interacting with Medicare and Medicaid in particular, and then secondly, the conditions of participation change. We had heard from along the way, we've seen signs from CMS that they were heading in this direction of requiring interoperability as part of the conditions of participation in Medicare and Medicaid. We weren't sure that they were going to actually take as broad a leap as they've done in this regulation. For example, in the physician fee schedule from last year and the inpatient prospective payment regulations from about 12 months ago, they asked questions around what would it look like if we what are the things that we need to be concerned about if we were to require interoperability and information sharing and allowing patients to bring their app, quote unquote, their app or their app of choice to the discussion when they sought care. And so they've information gathered for 12 to 18 months, and now they're really ready to jump. But truly, how organizations do that and how much comfort they'll have with knowing that the apps that patients bring to the encounter where they want their information downloaded to knowing that it's FHIR version 4 compliant and it has the security measures and the privacy measures in place is going to be real critical for the healthcare community.
Yeah, and I think we're going to learn a lot from patients as they start to do that. And, what is their comfort level? And I think we'll be able to evolve that. But I think they were pretty good about enabling patients but still addressing the concerns of many of the vendor community. So as I look at the legislation, I don't feel like there were a lot of huge surprises. What surprises did you see? Was it really just the payer side that they were so, I don't know if aggressive is the right word, but maybe that they've reached out in that payer side more than they have in the past? Was that the biggest surprise, or are there other surprises?
That's the biggest, and then to me the fact that that they chose to move forward on the conditions of participation. There was a lot of concern that CMS was going to hear from the hospital and the hospital community and the provider community and press pause or slow the process of leveraging the conditions of participation. So when they actually move forward with the program the way that they've outlined it, that to me I think is the biggest surprise to me.
Great. So which part of the legislation do you think is going to be the hardest for healthcare organizations to implement? Or, I guess there's both sides, healthcare organizations and vendors.
It's really, in terms of, from an information blocking and information sharing perspective, it's making sure that they put in place the processes that ensure that they're compliant with the requirements around API use, and that they're from a technical perspective, that they have the confidence that their partner, whoever their partner might be, whether it's another healthcare system, whether it's a patient's app, that they feel the level of comfort to be able to share that information, and then so we can get that information into the patient's hands. We've been talking about it for many years. The ideas have, the technology has caught up to the ideas that folks have about patient empowerment and patients truly being consumers. So that's, I think we're at the point where it's now time for execution. So one of the things that HIMSS has been looking at that I think ties very nicely with the with both rules, with the interoperability rules, is we created just a few weeks ago the Global Consortium for eHealth Interoperability, and the idea there is for this to be able to convene and help FHIR accelerator organizations not only accelerate their work on the use cases that they're developing, but also to be able to identify partners for them to be able to test their use cases in a real world setting, so that they can the tires can be kicked before you turn a use case, an API based use case can be turned over to the community. So every step that we and government and our partners, both HL7 and IHE, and then, in different communities are going to be part of this, making sure that consortium can truly deliver on creating a greater level of confidence amongst the provider and the hospital community and really the vendors, really all players, that they've got this greater level of confidence that they not only have the technology in place, but that it's working in a way in each use case that the information can be shared, and you won't get that ding on being an information blocker, and therefore have to either test against it or be able to go to court, or just to defend yourself. I guess you actually have that confidence, and where you need to leverage the exemption, you'll be able to, but where the technology can enable that information sharing, that it actually does occur.
It seems like one of the big challenges I see is understanding some of the fee structure around information sharing. They've made it abundantly clear patients shouldn't have to pay to access their information, But when it gets outside of that, and it gets a little confusing. Plus, if they're working with a lawyer, is that the patient requesting? Is it the lawyer? I think there's a lot of nuances people don't understand, and I think it's going to be really interesting to see all of that play out from a financial perspective. How are EHR vendors going to charge for it? How are providers going to charge for it? And it seems like we're still trying to understand that. But do you think it's pretty clear, or do you think that there's going to be a lot of learning and kind of trial by fire, if you will? Not to use the fire pun, but I guess I did. What do you think?
I think it's going to be a learn and progress process, if you will. We're technologically prepared to do certain, to make that information sharing occur, but there's exemptions have been identified to, in the event that your partner isn't technologically advanced enough, and you don't have to share something that's going to down the road negatively impact the patient. There's the different scenarios around being able to test your capabilities, the patient's appetite for how much information should be shared. I think that's all going to be a learn as we go process.
Yeah. So what part of the legislation do you think is going to have the most impact?
Really getting the information, requiring the Fire for version 4 enabled APIs, so that the information is available to the patient on in a way that doesn't require extra burden on their part, is going to truly empower the patient. If you think about, I just took my son to an orthopedist about 3 weeks ago, and sprained knee from wrestling, but we were sitting there in the lobby, and this family comes flying in, and they're barely on time, and one looks at the other, do you have the image? The other one says, no, I thought you had it, and the third person is just all worked up, and the person behind the desk at the orthopedist was able to say, well, where did you have the image done? And the answer was, whatever hospital, organization X, the radiologist down the street. Oh, we have access to their images, no problem. The level of stress in that family just dropped to the floor, first of all. So, because they don't know what they don't know what they don't know. They don't know what they have access to. So when you think about this information sharing and truly getting the information in the hands of the patient, so that it's, whether it's smartphone-based app or however it's available to them, that's really the opportunity, that it's in their hands, and being able to educate them on what they can do with it. Whether it's that family that the image is, that they have a greater comfort level in being able to check in, and part of the question might be in the future, hey, have you sure, have you gotten an image, and fill in the blank as to where the image is coming from, so that it's really helping to have smarter, more educated, more empowered patients. I think is really the opportunity that we've been talking about for years, but that we're finally ready to achieve. Another example is that same son. 10 years ago, he had a situation where we went to the pediatrician on one side of the street, we went to a specialist across the street, and then next door to the specialist was a clinic that was, super specialty clinic, and all of the information that had to be gathered for him to get back to the pediatrician was mailed to my house, and they didn't want it mailed to them. They wanted it faxed in. So then I had to drive to work and gather all the information, drive to work, and fax it to the pediatrician. We are light years ahead of that. And just think of what's going to happen with this, the information sharing components of these rules. That will be a distant memory, hopefully.
Yeah, we all hope, definitely. So as you look forward, are there, we already talked about there's going to be some telemedicine legislation, probably some exceptions to HIPAA and other things coming as part of coronavirus. Are there any other health IT legislations coming along? I think another national patient ID is one. I wondered, could it slip into some coronavirus legislations and things like that? Or are there any other things you're keeping an eye on, or are we just overwhelmed with 21st century and coronavirus?
Well, I appreciate the question, because what we're really looking at is, is this the year of privacy? Is this, 2020 and 2021, are they the years of privacy from a U.S. legislation perspective? There have been conversations for close to a year now about, hey, just take GDPR and overlay it over the top of HIPAA, and the multinational organizations that support, healthcare in Europe as well as here in the United States they'll be happier. They'll be able to provide better services to their healthcare clients, et cetera. And then there's discussion around, well, no, we can't just overlay somebody else's, some other entity's approach. We have to really understand how it's going to fit into the U.S. approach. So I think that 2020 and 2021 will absolutely be the years of truly updating HIPAA in a way that advances care delivery and consumer empowerment. And we're going to learn a lot from COVID-19. It's not just this social distancing that that we're all getting used to, and what the impact is going to have on communities. It's really from a healthcare policy perspective. What does it mean? What does privacy mean? What does information sharing really mean? And are we going to be able to tackle some of the, particularly the items that need legislative relief, that haven't been addressed since the mid-1990s? I would be remiss not to say cyber. Healthcare, there's a reason why healthcare data is the #1 targeted area, and why we need to keep making sure that everyone, that the policies stay on the forefront, but then the education for the smallest provider organization and the consumer, all the way up to the largest, multi-state healthcare delivery organizations, to the multinational market suppliers. That we all have to focus on the cyber component of keeping the information safe and secure.
No, definitely. And, word on the street I'm hearing is that the privacy legislation, the security legislation could be much broader than just healthcare, and it could apply to healthcare in big ways. So, I think it feels like that's where it's headed, is some sort of, well, it will be interesting to see if coronavirus hijacks this and pushes it to 2021, but the discussion is still going to happen around the privacy. When should data be shared? What are the rules around sharing it? GDPR, but I could see them going much further than that. Are you seeing something similar?
Well, yes, exactly. We're we even have staff over, HIMSS is our HIMSS enterprise reaches across the globe, and we happen to have staff available to us who are part of the healthcare team that developed or was provided input into GDPR, and do not just overlay GDPR into the U.S. environment. Let's learn and adjust, because GDPR even is going to have to adjust truly to the healthcare environment.
That's great. So, they're talking also about a $1 trillion stimulus package, or whatever number you want. It's some, I think, the president called it a huge, which is ironic that he'd use that word, but a huge stimulus package, a large stimulus package. Is healthcare going to get some relief, or is it probably just going to be mostly telemedicine? Any indications there or ideas, or is it still so black box and evolving?
If I had to guess, it's going to address some of the public health community's needs, as a result of COVID-19, but then also the idea of making sure that we answer the questions that, May 22nd is still a very much important date for there was an omnibus appropriations passed, except for certain parts of healthcare environment that were only funded through May May 22nd. Price transparency, in
Yeah.
pharmacy pricing, as well as funding for certain parts of the community health service level funding, absolute, and then workforce enablement programs have a May 22nd deadline that we have to address as a country. So I would imagine that that's going to all be part of this overall, whether you call it stimulus or just truly, filling in some of the appropriations gaps that are looming.
Sure. And it'll be interesting to see what it is called. Well, thanks so much for all your insights and perspectives, and catching us up on some of what's happening with even the coronavirus and also 21st Century Cures Act. I'm sure it's going to be a major topic of conversation for the rest of the year. Thanks everyone for watching this. We've been here with Tom Leary. He's the VP of Government Relations at HIMSS. Thanks so much for your time, Tom.
Thanks again.